All right. No. This is just connecting someone.
It's not very live.
All right, we are live. There we go. Yep, good.
All right. Well, hello everyone, and welcome to ASBMB Live. I am Raj Mukhopadhyay, the science writer for the American Society for Biochemistry and Molecular Biology.
And I'm Jeff Hunt, ASBMB's Public Outreach Coordinator. Welcome, everyone.
So ASBMB Live is a series where we bring together experts from a particular area of scientific research to talk about a certain topic. And it's a real-time interactive discussion with all these experts. Today's topic is about vitamin D and why experts still think that there's room for discussion. All right. Well, hello everyone, and welcome to ASBMB Live. I am Raj Mukhopadhyay. There we go.
Sorry about that.
Sorry about that. We're interrupting ourselves. So as I was saying, the ASBMB Live is an interactive discussion, and we have brought together four experts today to talk about vitamin D and why there is still an ongoing conversation over how much vitamin D we need to take in on a daily basis.
So as Roz mentioned, we have a couple of experts who are going to talk here, and I'm going to let them introduce themselves. We'll start with you, Michael.
So Michael Hollick from Boston University Medical Center, director of the Bone Healthcare Clinic, and have had an interest in vitamin D. My mentor, Dr. DeLuca, had introduced me to this more than 40 years ago.
Great. And then we have two folks from the University of Wisconsin. Go ahead.
Yes, I'm next. My name is Hector DeLuca. I'm Professor Emeritus, Biochemistry, University of Wisconsin. I've been in vitamin D research since 1960, so I've watched a lot of changes that have occurred. Although I'm emeritus and am officially retired, I still maintain a laboratory of about 20 people. So I'll pass that on to my colleague Wes Pike, who carries the load of studying vitamin D mechanisms.
So I'm Wes Pike. I'm a professor here in in biochemistry in the University of Wisconsin. I joined Hector in the university about 12, 13 years ago on his invitation, and have continued my work together with collaboration with him in much of the research that we've been doing on the vitamin D area.
Great. And our final panelist, Joanne.
I'm Joanne Manson, a professor of medicine at Harvard Medical School, chief of the Division of Preventive Medicine at Brigham and Women's Hospital, and I'm a principal investigator of the vitamin D and omega-3 trial, which is testing vitamin D supplementation in the prevention of cancer and cardiovascular disease.
Great. All right, so for those of you watching, we're going to start off the discussion with just a few questions ourselves, but if you have any questions or comments, please feel free to add them on our Google Plus page, and we will get them answered by the experts. So everybody ready to go?
Let's go.
Yep.
All right.
All right. Well, I guess we should first set the stage by discussing what's known about vitamin D. What is it, and what do we know so far of what it does?
You want me to start? I'll start. I'd like to start by reminding everyone vitamin D is not a hormone, but is a prohormone, and it's converted to an active hormone by two steps. First, in the liver, puts the 25-hydroxyl group on it, and then in the kidney, primarily but not exclusively, the 1-alpha-hydroxyl to form the final vitamin D hormone. And that is the hormone that we have all studied and is believed to carry out all of the currently known functions of vitamin D. So, and it acts very much as a steroid hormone. its receptor was cloned in 1988, and we know quite a bit about the receptor, its location, and we know quite a bit about how it does work, but we have a lot more to learn, and I'd say that Dr. Pike is one of the leaders in this area. Might want to talk a little bit about the molecular mechanism by which the vitamin D hormone actually carries out its functions.
So we learned a number of years ago that, as Hector said, that 125D3, vitamin D3, activates a protein in cells called the vitamin D receptor, and this receptor then is a typical transcription factor that interacts at the level of regulatory regions on genes and turns them on or turns them off. And we've learned quite a bit about many of the targets, although the mechanisms through which this regulation occurs is actually quite complex and involves many other proteins as well. One of the more recent avenues of research that has been very fruitful now is to utilize some what we call unbiased methodologies to explore the receptor's interaction at the level of the genome. And that has allowed us to identify what we would call overarching principles of regulation, where rather than looking at single genes, we're looking at maybe 2,000 genes that are simultaneously regulated either up or down in response to vitamin D. But this gives us an idea of cellular response to vitamin D and how that response can change very dramatically during cellular differentiation or in different cell types.
At a more fundamental level, the function of vitamin D, of course, through its active form, is to maintain blood calcium in a normal range, and it does that by increasing intestinal calcium absorption. And then it also goes to the skeleton, interacts with the osteoblast to actually increase the numbers of osteoclasts, which then can remove calcium from bones. So the function of vitamin D, 125-dihydroxyvitamin D, to make sure that your blood calcium remains in the normal range for most physiologic functions, neuromuscular function, as well as other activities.
So I think this nicely leads to the question of knowing about its molecular and physiological action, how do you make clinical recommendations based on that? I know it's a big, huge question that I'm asking here and covers a lot of ground, but perhaps you can, the four of you can walk us through how that's done.
The Endocrine Society had looked at a lot of the literature and also reviewed what the Institute of Medicine report had suggested as what should be vitamin D deficiency and insufficiency, and Joanne certainly can talk on behalf of IOM. But there was evidence that the parathyroid hormone levels were declining as 25-hydroxyvitamin D levels increased. There's debate as exactly what that level should be, but at least I think all have agreed that 25-hydroxyvitamin D of at least 20 nanograms per ml is needed for bone health, and there's a lot of additional information to suggest that maybe if you were to be above 30 nanograms per ml, that it may have some other biologic actions as well.
I agree. I think there's a lot of controversy about whether getting above 20 nanograms confers greater benefits. The Institute of Medicine did decide that a level of 20 nanograms for 25-hydroxy-D was sufficient for bone health, that vitamin D was essential for bone health, and there was evidence for a cause and effect relationship, and that there may be benefits of vitamin D in other tissues. Certainly the vitamin D receptor has been found in other tissues, and also 1-alpha hydroxylase. But the question is, what biological role is it really, playing a role in terms of preventing non-skeletal health outcomes, and whether getting well above the amount that was believed to be necessary for bone health would confer benefits for reducing cardiovascular disease, cancer, diabetes, and many other non-skeletal health outcomes. There continues to be a great deal of controversy about whether the relationships are causal once you get beyond bone health and whether higher levels of 25D would confer greater benefit than the levels that are recommended by the Institute of Medicine.
So going to that point about the controversy, can we get a little bit more into that about what the main points of contention are and sort of what are the two sides that people are, or maybe more than two sides that people are debating about this issue right now?
Well, the Endocrine Society practice guidelines had suggested that, yes, we agreed with the Institute of Medicine that vitamin D deficiency can be defined as a 25-hydroxy vitamin D of less than 20 nanograms per ml. But we felt that, at least for muscle function and possibly for other health benefits, that in fact you should be above 30 nanograms per ml. And so the concept of vitamin D insufficiency was introduced, and to be vitamin D sufficient based on the endocrine practice guidelines, that we thought that it was reasonable to achieve a level at least 30 nanograms per ml. Because there are so many different assays out there with some variability, and to be guaranteed that you're sufficient, the Endocrine Society recommended that a good range would be 40 to 60 nanograms per ml, and up to 100 nanograms per ml is perfectly safe.
Hector and Wes, do you have anything to add?
I'd like to, first of all, say that the functions of vitamin D beyond bone and maintaining serum calcium and phosphorus is really not strong enough to warrant making recommendations. We believe, due to the fact that the receptor is found in several tissues that signal that vitamin D plays a role, those roles have not yet been well defined, so it's been not possible to talk about what is the level needed to take care of this function, because we haven't defined the function. There's a debate whether there's an effect of vitamin D on muscle, for example. There is an even greater debate of whether there's a vitamin D receptor in muscle. And so one cannot really say we need vitamin D at 60 or 70 nanograms per milliliter to meet this need, because the need hasn't been well defined. The same is true for the immune system. These are areas of investigation, and one day we'll have that information that's needed to define what are the levels that are needed to satisfy these needs. But the needs have to first be defined, in my opinion.
I agree, and just finding the vitamin D receptor doesn't necessarily mean that it's expressed in those tissues in the normal state. And we don't really know whether supplementation with vitamin D will prevent these non-skeletal chronic diseases and health outcomes. Certainly, the observational studies do suggest an association between lower vitamin D level, lower 25-hydroxy-D levels, and increased risk of many chronic diseases, including diabetes and autoimmune diseases, and depression and infections, etc. But the randomized trials to date have been inconsistent and generally have not provided conclusive answers yet as to the benefits of vitamin D supplementation or achieving blood levels of 25D higher than those that are essential for good bone health.
Yeah, one of the major problems with the association studies is that it's not cause and effect, and so there's no doubt that there's lower blood levels in people with MS and so forth and so on. But until we can define how vitamin D actually works and have a defined mechanism, I think it's very difficult to say that the association means that it is correcting the disease. In other words, because the blood level's low, it doesn't necessarily mean that that's the cause of the disease.
I just want to add to that you know, we often say that correlation does not prove causation, and certainly there are many other potential explanations for a correlation between low vitamin D levels an increased risk of diabetes and autoimmune diseases and cardiovascular disease, many other chronic diseases. Certainly a low vitamin D level could be linked to poor nutrition, which is a risk factor for many chronic diseases, to getting very little outdoor activity, very little physical activity outdoors, which would then lead to lower vitamin D levels. And also obesity is linked to lower vitamin D levels, and obesity is a risk factor for many chronic diseases. And a general state of inflammation associated with chronic disease has been linked to lower 25-hydroxy D levels. So there are so many other reasons that vitamin D levels may be low in people who have chronic diseases or are at risk of developing chronic diseases, and it does not prove that the relationship is causal.
So I don't disagree, but just to put this into a little bit more perspective, when the Endocrine Society looked at the data, and especially there was this publication by Primmel in JBMR back in 2010, the author had concluded that when he looked at 675 Germans who had died, unfortunately, in an accident, ages about 20 to 90 years of age, and he looked at their bones and related osteomalacia, which is a measure for vitamin D deficiency bone disease, to 25-hydroxy vitamin D, he had concluded that you needed at least a blood level of 30 nanograms per ml. So from my perspective, independent of all these other effects, I don't think it's unreasonable for people to shoot for 30 nanograms per ml. I don't think that there's any downside to increasing it above that. And certainly at least the one study from Maasai warriors suggests that Maasai warriors outside every day exposed to sunlight, that their blood levels on average were about 40 nanograms per ml. And it could be evolutionarily that that's in fact what Mother Nature is teaching us, that it's mainly sun exposure that's always provided us with our vitamin D requirement. And probably achieving a level of 30 to 40 nanograms per ml is not unreasonable. And I think that there's no downside to doing so.
I actually agree, and I think that there's a pretty wide range between the recommended dietary allowances and the tolerable upper intake levels of the IOM. And the concern is not with getting to 30 nanograms. I completely agree with you, Michael, and even 40 nanograms is probably not associated with any excess risk, adverse events, but the IOM was concerned about blood levels getting above 50 nanograms will, and there is some association even in observational studies with some increase in vascular calcification and with cardiovascular outcomes and all-cause mortality. And certainly hypercalcemia wouldn't be expected to occur at that blood level of 25D, but once you get very, very high, there could be risks in some vulnerable populations. So I think the overall conclusion was more that more is not necessarily better. The evidence today is that it's very important to get above 20 nanograms per mil. There may be risks once you get to 50 nanograms per mil or higher. So I think it leaves a lot of discretion and latitude for having blood levels of 30, 40. And also I do want to emphasize that the IOM makes public health recommendations about the RDA and the TUL, the upper limit, but these are not clinical recommendations. There are many, many patients who would benefit from greater intakes of vitamin D or higher blood levels of 25-hydroxy-D than what is recommended for a general healthy population by the IOM. And certainly the Endocrine Society has many, many patients, clinicians are dealing with many patients who would benefit from the blood levels that were recommended and the intake levels recommended by the Endocrine Society. So I don't disagree at all. Patients who have bone health disorders or who have malabsorption syndromes or who take certain medications that can interfere with vitamin D metabolism certainly would be candidates for higher intakes and higher blood levels than may have been recommended by the IOM.
Yeah, and I agree. That's what the Endocrine Society had said, is that we were making recommendations for the treatment and prevention of vitamin D deficiency, and that was for physicians, not for the general population.
I'd like to take part in this for a moment, and that is, Mike, that German study really is about something that vitamin D does do, bone, and the fact that they found that 30 nanograms actually reduced the number of people or corpses that had osteomalacia is very significant, because this is one place where we know vitamin D works, and we ought to be supplying enough to be sure that all people will not suffer from this disease. Of course, if they have a metabolic defect in vitamin D metabolism, that's a different matter. They're resistant. But so I think that there is a range, and I'd also like to raise the question, I'm not sure that anyone can say that 25 hydroxy vitamin D levels above 50 are harmful, let's say below 80 nanograms per milliliter, between 50 and 80. There's no data. There are no data that show that this is harmful.
I agree 100%, Hector. In fact, one could argue that who in their right mind has a blood level above 50, right? So these are likely people that may have been vitamin D deficient that are now actually being treated for vitamin D deficiency. And when you look at those studies where this kind of uptick, the so-called J-curve, sometimes only about 6% of the total group are above 50. So I agree with you 100%. I've never been convinced that there's a so-called U-curve associated with increased toxicity.
Let me just say, one interesting thing is that throughout this discussion, we've been talking about 25-hydroxy-D levels, and yet that's not the hormone. The hormone is 1,25-D3 and not 25-D3, and yet we talk about circulating levels of 25 as being important. And I think what that brings up is the idea that different, as Hector said, different biological responses may require different levels of the hormone, whether it's produced through the kidney or whether it's produced locally through CYP27B1 expression in a particular cell type. Cells can respond and enhance their levels of 125-D3, and they can perhaps suppress it through overexpression of CYP24A1. So again, I think the idea here is that while one size may fit all in terms of the maximum level of circulating 25 one might want to see in a human population, there's no evidence yet that that concentration may be maximal or optimal necessarily for all biological responses, whether they're calcium and phosphorus homeostasis or whether it's muscle protection. So I think these are things that we don't really know about, and obviously one might set the higher levels as being appropriate for each biological the overall biological activities that are present in normal people, but we really don't yet know that.
So we got a question on Twitter, and I think this is a question that we need to answer to make sure everybody understands how we get vitamin D in the first place. The question from Carl on Twitter was, is there a plateau of how much vitamin D you can get from sun exposure? And that also brings the question of, are there differences between getting your vitamin D from sun exposure or from supplements? Is there a different mechanism of action of how you get your blood levels up?
Sure. So we had showed many years ago that when you're exposed to sunlight, you initially make actually pre-vitamin D from 70-hydrocholesterol, which is a precursor. And pre-vitamin D will then ultimately convert to vitamin D by a temperature-dependent process over several hours. But if you're continuing to be exposed to sunlight, instead of making more pre-vitamin D, the pre-vitamin D will absorb that sunlight and generate other photoproducts. So it actually sets up a photoequilibrium. And that's probably the explanation for why you can never become vitamin D toxic from sun exposure. So Mother Nature cleverly designed a system to prevent that from happening. In terms of oral versus sun exposure, a study that was done by Dr. John Haddad many years ago showed that the vitamin D lasts 2 to 3 times longer in the body if you make it in your skin, because it takes time for the pre-vitamin D to convert to vitamin D. It then takes, the vitamin D is made in a bloodless tissue in the epidermis, so it takes some time to get into your bloodstream, and then it gets in your circulation. 100% of it is bound to the vitamin D binding protein. When you take it orally, you instantly raise your blood level of vitamin D within 4 to 12 hours, and it rapidly comes back down. About 60% is associated with the vitamin D binding protein, which protects it, and 40% is associated with lipoproteins. And Dr. Haddad had considered that most likely that was more rapidly degraded. And so as a result, he had concluded, and we have similar data, that the vitamin D that you make in your skin lasts 2 to 3 times longer in your body than it does if you take it as a supplement.
Although I agree with everything that you said, I think we do have to be concerned about whether there should be clinical or public health recommendations to increase sun exposure in order to achieve the desired blood levels of 25-hydroxy-D or adequate vitamin D status, or whether we should be recommending vitamin D through food or supplements for that purpose. And the Institute of Medicine committee spent a great deal of time discussing this and decided that although incidental sun exposure should not be discouraged in any way, I mean, people obviously when they're outdoors being active and living their daily lives should not be concerned about getting some sun exposure and should be happy to do so, that we really did not want to recommend that people actually increase their sun exposure and with unprotected skin because of the very, very high frequency of skin cancers throughout the world. I mean, we're talking about 3 million cases of non-melanoma skin cancers, and there are also melanoma skin cancers linked to UV light, and so there were concerns about the adverse effect of recommending increased sun exposure in order to achieve the desired vitamin D status. So the IOM did not recommend increasing sun exposure, but rather the dietary recommended. The dietary intakes were based on very minimal or only incidental sun exposure.
So yeah, and what I've always been suggesting is sensible sun exposure. Even in Australia, the skin cancer capital of the world, they now actually are now recommending the so-called lunch sun exposure experience. So that is now encouraging Australians to get some sensible sun exposure. You can actually go to an app, dminder.info, and it actually will help you, guide you as to how much vitamin D you're making, and it actually tells you when to get out of the sun based on your skin type so you don't get a sunburn. I think that's the most important.
So one of the things I'd like to add to this discussion was the question of, is the vitamin D from skin different from that which you get in the supplement? The answer to that is no. There's no question that they're identical compounds. Mike's correct in that it does stay in the skin longer because it stays as pre-vitamin D. The DBP does not recognize pre-vitamin D, and so it's a slow equilibrium, and that explains why the lifetime is longer. The other point is that that vitamin D intoxication doesn't happen from sunlight, not only because of the mechanism you were talking about, but it actually bleaches the 7-dehydrocholesterol in the skin. There's a limited supply. It's converted, and some of it goes to the toxisterols, which are ineffective, and that also contributes to a limitation in the amount of vitamin D produced by skin. So they're both useful, but I think we do have to be aware, as Joanne says, that sunlight does cause lesions that probably result in cancer, and so a certain amount of limitation, I think, Mike, is in order. Don't you think?
Agreed. That's why I said sensible sun exposure. So you get an amount of sun exposure that does not cause a sunburn. And just the data are pretty clear, is that it's mainly exposure on your face and hands that increases risk for non-melanoma skin cancer.
But you know, we have an alternative to skin production. We can take it, right?
Correct. And so I have no problem with that.
With no risk, right?
The problem, though, is to try to convince everybody, children and adults alike, to be taking a supplement every day. That's going to be impossible. You should really be fortifying more foods with vitamin D. That I agree with, right? And so some sensible sun exposure is okay. What I'm suggesting is you don't always have to wear a sunscreen. like the dermatologists tell you, you should never be exposed to one direct ray of sunlight.
You know, they say one photon is too much. But,
Right. So,
you know, and I don't agree with that. I agree with
Go overboard. We should. I agree with the sensible approach.
So let's take this to sort of looking forward in the field. And Joanne, I'm going to ask you to talk a little bit about the VITAL study that you're involved with, and then if everybody else can sort of chime in on sort of, you know, what are the next steps and sort of where is this field going. So Joanne, can you sort of describe for everybody, you know, what is VITAL, you know, what is it looking for, and how is it going to take what we know and move it forward?
Well, we are conducting a nationwide trial called the Vitamin D and Omega-3 trial, which is testing 2,000 IUs a day of vitamin D3, and in a factorial design, also testing the omega-3s, EPA plus DHA. So we're able to look at the independent effect of each of these interventions as well as a possible joint synergistic effect of these two supplements. We have as our primary outcome in 25,875 men and women throughout the country the prevention of cancer, total cancer, as well as some site-specific cancers we have a special interest in, including colorectal cancer, breast cancer, prostate cancer, and lung, as well as cardiovascular outcomes, including heart disease and stroke. We have, in addition to those primary outcomes, several ancillary studies that will be looking at an effect of vitamin D3 or omega-3s on prevention of diabetes, cognitive decline, mood disorders, depression, autoimmune diseases, infections, respiratory diseases, and many, many other outcomes. We have, in addition to looking at these major outcomes among the total cohort of equally divided men and women, and we have over 5,000 African Americans, so we're hoping to be able to address the question of whether vitamin D supplementation can reduce health disparities that occur by race, ethnicity. We also have a smaller group of 1,000 participants who are seen in the clinic and have very detailed testing, including a 2-hour oral glucose tolerance test, anthropometric measurements, and height and weight and waist circumference, hip circumference, and blood pressure, a careful assessment of blood pressure, a 2D echocardiogram, ECG, spirometry, detailed assessment of physical performance, muscle strength and balance, and a number of the physical performance tests that are so important to preventing falls and improving physical function as we age. And so overall, in 1,000 participants, we have very in-depth phenotyping of those participants. Now we have blood collections in close to 17,000 of our nearly 26,000 participants overall. And in those 17,000, we are measuring the 25-hydroxy-D levels as well as the EPA, the fatty acid level. And we're in the process of pursuing the measurement of bioavailable vitamin D, the vitamin D binding protein, and calculation of the bioavailable, as well as direct measurements of the free vitamin D. We actually are collaborating with Michael Hollick. Mike is a consultant to the trial, and we're working closely with him also on this issue of measuring free vitamin D. And what we would like to be able to do is evaluate whether the baseline level of 25-hydroxy-D or bioavailable or free, whichever turns out to be most predictive, actually is important in terms of modifying the effect of the intervention. For example, do we see that it's really only those men and women who start out with blood levels below 20 or below 30 who have benefits from vitamin D supplementation? Or are benefits seen more widely throughout the entire study population? Or does it really just make no difference, and is there no benefit of vitamin D supplementation? They always have to consider the possibility that the results will be neutral or that risks will be identified, but we're looking very closely at the balance of benefits and risks in terms of a number of health conditions and chronic diseases. And we're also monitoring very closely blood calcium levels, PTH levels and their changes with supplementation, and looking at whether there are any concerns such as development of kidney stones, or hypercalcemia. We don't really expect that either of those will be problems, but we are monitoring them very, very carefully.
So to follow up on that, we got a question from one of our viewers who asks about the connection between vitamin D deficiency and liver disease. So is there anything known about that? Is there anything other than some stuff? What have the studies shown?
Maybe I can help you.
At 25 hydroxylate, that's going to be a problem. But Mike, do you want to go ahead with that?
Sure. Also, the problem, actually, the major problem is that when you have liver failure, you have malabsorption. And so, therefore, they're malabsorbing vitamin D. And as a result, they often need more vitamin D. But as Joanne had mentioned, also, of course, the liver is the major source for 25-hydroxyvitamin D. But the liver has a huge capacity to make 25-hydroxyvitamin D. And so we and others have shown that you really have to lose about almost 80% of liver function before the 25-hydroxylase is not active enough to be able to maintain blood levels. So the major problem with liver disease, from my perspective, is that it's a malabsorption problem that you can sometimes overcome by giving more vitamin D.
And we got another question on Twitter that was asking about what do we know about the expression, about the vitamin D receptor between different different muscle types.
I would say that I don't think we know very much about vitamin D receptor expression in muscle at all. There's clearly a controversy with regard to detecting the receptor in that particular tissue, as well as tissues such as liver and brain. And when it comes to many of the analyses, many other cardiovascular system as well, there's a suggestion that receptors are expressed there, but the detection is very difficult, and it's easy to become confused as to whether there's a receptor expression or whether there's artifact associated with that. As a result, there's considerable confusion. There's no question that in some of these tissues that we argue are targets of vitamin D action, whether they're direct or indirect, may have receptors expressed there, but the levels are extremely low. I don't think there's any question about that, and so the consequence of that is try to understand whether those very low levels are very cell selective or whether they mediate biological activities at all. So there's a tendency to assume that there's receptors there and that they do all the action, but that's really not necessarily the case.
I also want to remind everyone that if you look in the literature, there are some papers that maintain that the vitamin D receptor is found in all tissues, and there's an awful lot of data that are poorly done, poorly controlled, that come to, I think, incorrect conclusions. There's no doubt that muscle, heart muscle as well as skeletal muscle and smooth muscle, contain very little, if any, vitamin D receptor. And the existence of a transcript in very low concentrations does not constitute evidence that a receptor is present. So until one can show that there is a function in that tissue that requires the vitamin D and the vitamin D receptor, and you find the receptor in sufficient quantities there, it's a non-issue. So I'd say that the evidence for direct action of vitamin D in muscle isn't there, but there certainly is plenty of evidence that vitamin D affects calcium and phosphorus, which in turn affect muscle strength and muscle capability. That's certainly true also. So there is an effect, but it could be indirect.
And actually, Michael, we've had a viewer ask you again for that. Was it an app that you mentioned that you can figure out how much sunlight exposure you need?
DMINDER.info on Android and on the iPhone.
Okay.
And if I could just carry it one step further with what
Sure.
Dr. DeLuca said, is that all of what he said is correct, but it is curious and interesting that 1,25-dihydroxyvitamin D interacts with a receptor in skin cells, in keratinocytes, and it will modulate differentiation. And the use of active vitamin D, active form of vitamin D, including its analogs, is one of the first-line treatments for psoriasis. So this actually gives an insight, potentially, into other biologic functions of 1,25-dihydroxyvitamin D, and maybe at least kind of giving us an inkling as to why maybe many of these association studies related to decreased risk for some cancers, including colorectal cancer, may be true, and related.
Cool. All right, so we're going to give one last chance for our viewers to submit some questions, and while they're thinking those up, I'm going to give each of you 2 minutes apiece to sort of give us your big picture concluding statement about vitamin D, about what's left unanswered and sort of where we're going, but try to keep it concise. So Joanne, we'll start with you.
Well, I think that we need the large-scale randomized trials, and we should have conclusive answers within 3-4 years to many of the questions we've been talking about. There are several other large-scale trials being done around the globe, including a vitamin D trial in the United Kingdom and Finland, Australia, New Zealand. As we've discussed, the VITAL trial, and there are also some smaller trials that are being done in the U.S. and abroad. And these trials are looking at muscle outcomes, physical performance and balance and falls, and they're looking at cardiovascular disease and cancer and diabetes, and a number of chronic disease outcomes, as well as infections and acute illnesses. And I think that these trials will give us a lot of information about the balance of benefits and risks to guide recommendations, public health recommendations, as well as some of the clinical recommendations about the amount of vitamin D that is really optimal for health, and also tailored to other conditions, such as people who have underlying bone health problems or have certain comorbidities, whether they would benefit from more vitamin D. I think we will have many of these answers. I just urge everyone to stay tuned. Be sure to avoid vitamin D deficiency, but don't assume that more is better. Megadose vitamin D really the risks may even outweigh the benefits. We don't know yet for sure what the balance of benefits and risks will be of high-dose vitamin D supplementation.
Cool. Wes, you want to go?
So I'm a basic scientist, and my primary interest has been in how the vitamin D receptor regulates genes, and in so doing regulates a variety of biological responses, not only in bone cells and the intestine and so forth, but certainly how it might regulate, whether novelly or through a vitamin D receptor mechanism in tissues such as muscle. One of the areas that I think will be most interesting, and I sort of touched on it earlier, was the relationship between 25-hydroxy-D and 1,25-D3, because 1,25-D3 made in the kidney is an circulating endocrine hormone, but it appears that it's very possible that 1,25-D3 is being made in various cell types in the body. Whether it's as ubiquitous as seems to be suggested needs, again, some hard evidence, and that still remains outstanding. But the relationship between 25-D3 and 125 in cells and tissues, and what that relationship is to the activation of the receptor, and how cells can actually utilize the expression of the enzyme that makes 125 from 25-hydroxy, and how it utilizes CYP24, which is the enzyme that degrades 125, to maintain set points, individual set points in different tissues to mediate biological response. So the question will be whether different tissues and different responses to vitamin D require really different levels or a different balance between the prohormone 25-D3 125D3, which again is the steroid hormone itself. It's the only one that activates the receptor.
Cool.
Hector?
Well, I'd like to, again, I'm a basic scientist as well, and so I believe that we know that the vitamin D receptor is found in many, many tissues that have nothing to do with calcium, phosphorus, and bone. And I think it signals that vitamin D has multiple actions that are yet to be discovered. And so, for example, the immune system, we know that the vitamin D receptor appears in various immune tissues. We have yet to define exactly what happens to the immune system in vitamin D deficiency. Certainly, vitamin D deficient animals can fight off infectious disease, but that's not the whole story. So I believe we have a lot to learn about what the various targets that 125-dihydroxyvitamin D3 has, and we should be spending a lot more time trying to figure out what it's doing outside of bone. But that is to say that we know everything we need to know about how it works on the bone, and I don't think that's true either. And I think Wes's work, for example, looking at all of the genes that are activated and those that are suppressed, and there's an anabolic action of vitamin D on bone that has yet to be explored. So I think we have a lot of basic science left to be found out about this vitamin. I also believe we don't know everything about metabolism that we think we do at this stage. We need a lot more basic science done on this vitamin than has been done so far. We've made some pretty good progress, but I think we're burying our heads in the sand when we're saying we know a lot and we're going to explore this. I think we got to look further. The receptor in different tissues is trying to tell us something. Let's go after it. So I'd say I'd like to see a lot more basic science done on vitamin D and its metabolites.
Michael?
So I agree with all of the three speakers, and my message is that I think everybody agrees that vitamin D deficiency is a common medical problem worldwide. CDC had reported 32% of children and adults in the United States, 25-hydroxyvitamin D of less than 20 nanograms per ml. In my opinion, and the Endocrine Society recommends, children should be on 600 to 1,000 units of vitamin D a day, and adults 1,500 to 2,000 units of vitamin D a day. For obese people, because they wind up diluting the vitamin D in their body fat, they need 2 to 3 times more vitamin D to satisfy that requirement. I also agree that we don't know what the blood levels of 25-hydroxyvitamin D should be for bone health versus maybe some of these other biologic effects. And I think a lot more research needs to be done to be able to clarify that. But the bottom line for me is that there's no downside to increasing your vitamin D intake. I agree with Joanne, not mega doses. Get levels in the 40 to 60 nanogram per ml range, which is what the Endocrine Society recommends. And take your supplement and get some sensible sun exposure. And those two, I think, in combination will help maintain good health throughout your life.
So we did get one more question from one of our viewers, and the question is there a way to figure out, a better way to figure out what a deficiency is, because a body could be deficient yet not show the symptoms of deficiency. But if I understand correctly, these days you know if you're deficient by doing a blood test. In the olden days, I mean like a century ago, people would know they were deficient when they got osteomalacia and rickets. So basically the person's asking, is it possible to be deficient but not know it?
So it's a good,
that we now test for vitamin D?
Yeah, it's a good question, and that's part of the problem. So when you're vitamin D deficient, it's really very subtle are the effects, clinical symptoms that you would pick up in the clinic. Sometimes you could pick up a lower bone density, for example, in both men and women, but otherwise you don't really, it's not like other vitamin deficiencies like vitamin K, for example, or vitamin A, where you have problems with clotting or you have problems with vision. So it's a much more difficult issue. One thing that I'm sure maybe Wes may want to comment on, and we've done as well, is that maybe actually it's your genes that ultimately know your vitamin D status, and which genes are being turned on and turned off in response may be different for different people. And so it may be that the 25-hydroxy vitamin D assay, as good as it is to determine vitamin D status, is not good for an individual, because every individual may be responding differently. And as Joanne had pointed out, this issue of vitamin D binding protein polymorphisms and how it binds the 25-hydroxy vitamin D, how well does it do in releasing the 25-hydroxy D to target tissues. None of this we do understand very well, and I agree with the questioner that we probably need a better way to determine how our individual body responds to vitamin D and what is sufficiency for our individual body.
Awesome. Well, I think that's a great way to wrap things up here. Thank you, all of you who are watching. A big thank you, of course, to all of our panelists and for their willingness to participate and sort of debate this issue a little bit more. If you want more information, we'll post some of these links on our Google Plus page, but Raj wrote a story in this month's issue of ASBMB Today about this whole issue of vitamin D, so you can check that out. Of course, there are the reports that we talked about from the Institute of Medicine and from the Endocrine Society, along with a number of other papers, including one from West that I believe is coming out in JBC.
Came out last week.
Came out last week. So we'll plug all those things, and we'll post links to those on our Google Plus page. You can also go to asbmb.org to find more information.
Well, thank you, everybody. And if you have any further questions, for those who are still watching, you can post them, and we can always ask our experts and get back to you later. So thank you very much.
Thanks, folks, and we'll see you next time.
Thank you. Have a delightful